Hey guys, sorry I got us behind a little bit already, but this is an important chapter. It will probably go faster this way. Not a lot of stories, pretty cut and dried material, but it's critical that you know it and understand it because we're going to build all of our rehab protocols around this idea of how long it takes these tissues to heal and to remodel. So, didn't want to just skip it and expect you to learn it on your own. Wanted to at least give you this, so we'll go through this relatively quickly. Um, we're going to take a look at connective tissue and the specific types, look at the mechanical properties of that tissue, see how it responds to injury, see how it responds to periods of immobilization, and then the remobilization is really, if immobilizing it causes certain negative consequences, then remobilizing usually neutralizes those consequences, so that part will go pretty quick. All right, most basically, it is impossible for us to do anything that accelerates the healing process. Okay, physiology is physiology. However, we can optimize the environment so that that process can occur as quickly as possible. So, anytime we've got an athlete who's injured, and say we're getting pressured from the coach or from the parent or from the athlete themselves, healing takes time. Okay, so it's our job to optimize that time, but we can't accelerate that time. Okay, knowing that, we've now come to understand that early motion can maximize our efforts to decrease swelling, keep muscle tone, keep muscle activity, minimize bone loss, minimize the weakening of connective tissue. Okay, so that old RICE acronym doesn't hold true anymore, as we've talked about several times in class. Pure rest is very rare. If they've got concussion, then that may be one exception. If they've got some sort of cardiac issue, that may be another. But for most musculoskeletal issues that we're dealing with, they don't need complete rest. They need some sort of optimal loading. Even if they're in a cast, we can still do isometrics. We can still do activation work so that we are trying to maintain those neural pathways, try to minimize loss so that when we are able to bear weight and we are able to introduce force, we're not having to play such a big game of catch up. Okay, so immobilization itself is detrimental to the healing process. Even if we were healthy and we stuck each of us in the class in a cast for 6 weeks, even though there's no injury to begin with, we would introduce injury, and it may result in a permanent impairment. The longer we are immobilized, the more likely those changes are to be irreversible, whether it's range of motion, whether it's strength, whether it's some combination of things. But the bottom line is our athlete doesn't recover to the extent we would want. Okay, so when we look at connective tissue, we're considering collagen, elastin, reticulin, ground substance. The qualities of these tissues vary according to the structure. So the structure very much determines the function. So depending on the injury we're dealing with, the appropriate treatment could be cross-fiber friction massage, it could be stretching, it could be strengthening. It really depends on what tissues we're dealing with. And in some instances, we're dealing with multiple tissues. Say we've got a deep laceration. Okay, the skin's going to respond much differently than the muscle if it's cut all the way through down into the muscle tissue. So what's good for the more superficial tissues may not be what's optimal for the deeper tissues. So we don't necessarily want to treat one without addressing the other. So it's a good reminder that, in the case of a significant sprain, okay, there's ligament involved. Well, is there also tendon involved? Was there a reflexive contraction that resulted in an avulsion or a tendon disruption of some sort or muscular injury? In which case, what's good for the ligament may not be what's ideal for the muscle or the tendon. So we need to remember that. Okay, collagen is basically structural protein. Okay, When we look at endomysium and the connective tissue that makes its way in, around, and through the muscle tissue, that's collagen. Okay, it does break down with age. One of the reasons we tend to lose flexibility as we age is because collagen does break down. Four main types. Type 1 is usually not particularly, well, I take that back. Type 1 collagen is found in skin. It's also found in tendon, can also be found in bone. Type 2 cartilage, type 2 collagen forms cartilage. Type 3 is granulation tissue. That's what I was thinking about when I initially started talking about type 1. This granulation tissue is not as structured, as organized, and as a result not able to bear load as well as type 1. And then type 4 we find in cell membrane, so it again provides structure. Elastin is a specific protein that, as you would guess from the name, I mean, if I look at this, it reminds me of a big rubber band ball you might see at Staples or Office Max or something. Elastin provides extensibility so that structures can return to shape after they've been deformed. We certainly see this in skin. So like we said, if we had a laceration or maybe a deep abrasion, then elastin is involved, and there will be a period of time in which that skin is not elastic because that granulation tissue is taking its place and it hasn't been remodeled yet. Even post-surgical, we will see that same thing where elastin hasn't been laid back down in its place. We also find it in arteries, find it in ligaments, cartilage, and the bladder, which is thankful. Some of us have to pee too often as it is. Okay. Reticulin is structurally similar to type 3 collagen. Like we said, type 3 collagen, less orderly. You can kind of think about this as a collection of strings, and they're not, they're not laid in any particular order. We see the orientation moving in different directions, different planes, which hampers the strength of this tissue. Reticulin is an important intermediate tissue. Our body will utilize type 3 collagen and reticulin during the healing process, but hopefully that's temporary. Through loading, we can hopefully trigger the remodeling of that tissue to look more like what it was prior to injury. Okay. Ground substance, we've got areolar or loose, where you see lots of air, lots of opening, versus dense connective tissue, where we don't have that opening. The more parallel we see the fiber arranged, the more that tissue is optimized for strength. The more random that appearance, like we saw with reticulin, the less strong it is, but the more it can facilitate movement in multiple planes. And then the dense irregular gives us kind of a happy medium. We get added strength because of the density of the tissue, but the random orientation allows movement in a lot of different directions. Okay, so connective tissue really serves a number of purposes, and anytime we've been immobilized, we start to discover that those purposes aren't being met by that tissue. Okay, so first thing is elasticity. It allows tissue to return to normal length after elongation. Okay, think about an ACE bandage. We can stretch it out. If it's good quality and we haven't overstretched it, when we let it loose, it returns back to its normal length. Okay, we'll certainly see that in muscle tissue. We'll also see that in ligament. Okay, that's not the only thing that connective tissue allows us to do. It's also viscoelastic. Okay, and this visco refers to fluid movement. Think about that like a shock absorber. Okay, this is a column within a column with fluid in between, and as we compress that structure from end to end, it resists. It absorbs shock. Okay, it resists deformation, but not completely. If this were just a rigid, solid bar, it would prevent all movement, but it wouldn't absorb any shock. Well, you think about how landing with a flexed knee with the foot flat or on the front third out on the metatarsal heads, how that allows us to absorb force so that it's not transmitted up to our spine. And even for that matter, our spine and our intervertebral discs have viscoelastic properties that resist deformation but don't prevent it completely. Okay. And then lastly, plasticity. So this is a bowl that's been in the microwave. Plastic bowl, probably had butter in it. It's melted, it's deformed. Unlike elasticity or viscoelasticity, where we're going to return to shape following some sort of load or force, with plasticity we've got permanent deformation, and that may be a good thing in some instances. If we've got joint contracture and the athlete hasn't been able to move for weeks or months at a time, we are hoping that that plasticity is still there. You know, a frozen shoulder that has been that way for years, we're probably not going to be able to alter the plasticity of that tissue. It's pretty well rigid. All of these properties occur simultaneously within connective tissue. Okay, so it does have the ability to do all three, depending on how it's being utilized, and for that matter, how we are stressing it with our exercise progressions or with our drills and skills and such. Okay. Force deformation refers to how we can deform tissue. And again, this may not necessarily be injurious. This may be something we want. We want to introduce range of motion. We're looking for force deformation. So how much force is required in order for a change of length or deformation to stick around? Okay, so you think about silly putty. If you just barely pull on the silly putty, it really doesn't change. But if you apply force slowly and an adequate amount of force, it will deform, and once we let go of it, it stays deformed. Okay, so there is a time component to this as well. We start considering contractile structures. We've got to consider the influence of the GTO and the muscle spindle fibers as well. But force deformation is certainly something we can use in rehab with a lot of our static stretches and our joint mobilizations as we're trying to increase range. Okay. Creep refers to low-level force. So unlike what we saw with force deformation, with creep, this is relatively low force. So think about this as almost cumulative trauma. Low-level force over time results in a permanent deformation, plastic deformation. This can be influenced with heat. This can be influenced with time. So this is a slinky. I don't know if you remember that or not. Before they were plastic, they were made out of steel. And if you stretched your slinky and let it loose, it would recoil. Okay? But over time, if you were to stretch that and continue to stretch it and continue to stretch it, and every day you moved it another inch out, at some point it would reach a point where it would be sprung. Okay? It would no longer recoil and fit in the box anymore. If you were to heat that up with a torch, you would actually speed that process. Well, we don't heat muscles up with torches, but we do heat muscles up with blood flow, with activity. So if we are looking for low-level force application over time, we can leverage those capacities to help us. This can also rear its head on the injury side. Okay. Something like a stress fracture. We've got a cross-country runner who's repetitively loading. Any one of those steps isn't enough to cause that tissue to yield. However, the cumulative result of that loading is enough to cause that tissue to ultimately yield and fail. Okay. So when Nathan Burgess comes in to talk to us about PNF, we're going to talk more about GTOs and muscle spindle fibers. And we've also talked about this in terms of just strength and conditioning before. But it bears repeating that muscle spindle fibers are activatory. So if a muscle spindle fiber reaches threshold, then it basically recruits the muscle cells around it to contract. Okay. There are two types of intrafusal fibers. So intra within, fusal refers to the cells around it. And nuclear bag fibers are one particular type of intrafusal fiber. They are sensitive to stretch as well as the rate of change in that stretch. Okay? Whereas nuclear chain fibers are sensitive only to stretch. They don't necessarily check up on the rate of loading. Lots of times when we talk about rate of loading, we're more concerned with the GTOs. But just bear in mind that the muscle spindle is sensitive to both the amount of elongation, amount of change, and the rate at which that happens. So here you see a nuclear bag fiber. Here you see the nuclear chain fibers. Okay, and then the muscle tissues surrounding it. Okay. Now, like we said, the GTOs are not in the muscle tissue. They are actually embedded within the tendon itself. Okay, so these are long tubular capsules. They are less sensitive to stretch than the muscle spindle, and that makes sense because tendon isn't as elastic as muscle. They are sensitive to muscle contraction. They sense the amount of tension through that muscle tendon unit, and if they are stimulated, if their threshold is reached, then it's their job to deload the system. And the way they do that is to shut off the contractile fibers that are loading the system. Okay. As we've said before, this is trainable. So the threshold at which these GTOs kick in is necessarily higher in an untrained athlete. Okay. It's also necessarily higher in an athlete that's been immobilized or has undergone a prolonged lack of loading, we'll say. Okay. If they've been under activity restrictions for weeks at a time, then their GTO response is probably going to be greater than it would have been if they were healthy. Now, we don't do anything to necessarily address that directly. It's not like we do drills or skills to alter the GTO sensitivity, but indirectly we do. Okay, so this is one of the reasons why adequate loading during late phase rehab is necessary, because it helps preserve power. If the GTO doesn't change, if it still keeps that high threshold, we haven't introduced any high intensity exercise late phase, and we put them back out on the field, then their system is still going to be overprotective. And what I mean by that is if they drop into a deceleration movement where they drop into a squat and the threshold is reached for the GTO, then what's that mean? That means the quads are going to be inhibited. Okay, so that's going to potentially expose them to greater risk of injury at the worst, and at the very least it's going to compromise performance. Okay. At the same time, if this GTO is triggered, let's say in our quadricep, we get inhibition, the hamstring is actually activated. So we'll learn about some specific ways in which we can manipulate this process through PNF so that we can get activation. If I'm trying to activate the quadriceps, if I can activate GTO on the hamstring, then I'm actually going to activate and assist with quad contraction. Okay, so these are protective mechanisms. If the stretch is applied too quickly, then the muscle contracts because the spindle fiber is activated. If it's applied slowly, then the muscle relaxes and we get GTO inhibition. So a lot of our static stretching is intended to get the GTO to help out. A lot of our PNF work is intended to get the muscle spindle active so that we can increase recruitment. Okay. Anytime we've been injured, usually we will undergo the process of inflammation, and you've learned all about this in modalities. Where this becomes especially problematic is when we've got repetitive injury or microtrauma. Okay, so this cumulative effect causes injury, insult in the joint and the surrounding structures. Okay, hemarthrosis, some sort of irritation of the joint lining. I mean, it can manifest in a number of different ways. We have to be careful during this process, but we don't have to just completely shut them down. Okay, so gentle range of motion, even isometrics, postural stuff, working on non-involved body parts, that's much preferred over outright rest. So we modify training and conditioning. We protect them from additional insult. We load them optimally. Sometimes that means body weight. Sometimes that means less than body weight. But it's relatively rare that we will completely unload them. In those circumstances, we want to get them back to loading as quickly as we can. But that's the idea. Ice compression, elevation being the rest of that acronym. Okay. Inflammatory response is the same. It doesn't matter where it is. It doesn't matter what triggered it. It's a chemical process. It's a metabolic process. There are changes in cell membrane permeability. There are changes in the surrounding vascular structures. And then eventually we'll get some sort of repair. Okay. So if we sustain a strain in our hamstring, we've got primary injury. We've got tissue at the site that has been damaged. Cells are actually dead. Okay, and then we also have secondary injury as a result of this chemical, metabolic, cell membrane permeability, vascular change, where the surrounding structures that weren't killed, cells weren't killed during the initial insult, are compromised following the injury because of the changes associated with it. Okay, so we've got an initial trauma. Okay, primary injury may result in a hematoma. In the case of a closed wound, in the case of an open wound, it may clot and scab. Okay, so what this, and I don't expect you to memorize this chart, but what this tells us is if rehab is adequate, we get optimal recovery, we get a return to full activity, and then our risk of subsequent re-injury is less. Okay? We can't prevent all injuries though. Trauma will lead to a problem here. Okay? If you look at this side of this flow chart, if rehab is inadequate, we continue to have pain, we go back to activity anyway, we're actually at greater risk of injury because of the inadequate rehab. Okay? For many of our athletes, they kind of simmer here in an inflammatory condition. The pain spasm cycle, pain causes spasm, spasm causes pain, and they kind of stay here. The risk of re-injury continues to be elevated because we're going to have inhibition. Okay, so what you see here is we can't prevent that initial insult. Okay, this happened. This secondary response that occurs from changes as a result of that injury further complicate things. Okay, so our rehab has to adequately address everything associated with that injury. Okay, so you might not have ever considered, but there is a hypoxic site there. So some of the things we do are actually intended to increase blood flow through the tissue. Now, many of these things we've done without necessarily being real purposeful about them over the years. Okay, but just as I said in class, if we develop that problem list, the more specific we are, the better we're going to be able to prescribe exercise for it. So I guarantee you, early in my career, I wouldn't have looked at a hamstring strain and put the fact that there's secondary hypoxic injury on the problem list. But if I do, well, how am I going to treat that? Active motion with little to no resistance. When I was with Oakland, I was introduced to a treatment technique called O2ing, where next to no resistance or no resistance, we'll put them on a slide board with a towel around their leg, baby powder. They're just going to move that leg through active flexion and extension for 10 minutes. And they're going to flush that area with oxygenated blood. We're not overloading the tissue. We are simply flushing it with oxygen to address that particular problem. Okay, so if we're talking about soft tissue, that initial inflammatory phase, anywhere from 0 days, if it's relatively minor, to up to a week. The repair and regeneration can take up to 3 weeks, and remodeling can take up to 2 years. Okay, and I've got the crystal ball here because right now you might not necessarily know how to tell based on, a grade 2 ankle sprain. How long is it going to take? Well, every athlete's a little different, but if you see enough of them, you start to understand what is pretty typical. If we're talking about an osseous injury, a fracture, the acute phase of healing, about a week. Repair and regeneration up to 3 months, and remodeling again. We may see evidence of a fracture. We'll see evidence of a fracture forever, but we'll see active remodeling up to 2 years. With peripheral nervous tissue, we'll get an initial degeneration where that distal axon will actually deteriorate substantially. And then if it's a myelinated nerve cell, then that remyelination may take months or even years to occur. So remyelination may start about a week after the injury, and it occurs at a rate of 2 to 4 millimeters a day. And keep in mind that those cells are continuous. So in order for that nerve to be fully healed, and it's going to start distal and work its way proximal, if we've got a peroneal nerve injury and that from root to the distal tip is 32 inches, you consider the fact that that's more than 800 millimeters at 2 to 4 millimeters per day. You're looking at over a year for that one cell to recover. So it's no wonder why it takes so long for nerve injuries to recover. Okay, with muscle tissue, see that kind of same idea there. As we've got that first week, and then we move into repair and regeneration for the following 3 weeks, and then remodeling and maturation up to 2 years. All right, so we talked previously about primary injury versus secondary injury, and the thing to remember here is that secondary ischemic death, so we've got a compromise in blood flow to the area, and those cells are basically starved of oxygen. We do lose those cells, but the loss of cells also creates other issues. Okay, think about it like a hurricane. A hurricane sweeps in and tears down houses. Well, the destruction of the house is only the first part of the problem. In order to build a new house, the next thing you have to do is to clear all the debris. Okay, so in the case of secondary ischemic cell death, we also have chemical issues that arise from that cellular destruction. Okay, we get hematoma, blood collecting in the area. We also get inflammatory mediators like histamine and bradykinin that alter vascular permeability, and we get fluid shifts that we didn't have before. So the net result is we get increased edema. We've got swelling in the area, and swelling leads to both a loss of range of motion and an inhibition of muscles around the area. Okay, so during that acute inflammation phase, what would your likely problem list be? Okay, we know we've got edema, we've got a loss of range of motion. Just said we've got a lack of strength due to the likely inhibition of those muscles. So our primary objectives of treatment are going to be reduce edema, increase strength, increase range of motion. So using something like a yellow TheraBand, although it's not a lot of resistance, it provides some resistance. Active range of motion, putting them on a BAPS board, treating the edema directly with a Game Ready or compression sleeve of some sort, ice, elevation, all those types of things are intended to address that particular item on our problem list. Okay, so initially we get, if we're talking an intra-articular problem, then the synovial membrane will also undergo some changes, and if that happens repeatedly, then we can end up with chronic synovitis. Okay, that can lead to an increased cellular death. White blood cells are going to ingest lysosomes and those proteolytic enzymes. They're going to die and release what was ingested, and then over time we're going to cause further damage to the joint structures. Okay, if we've got chronic synovitis, that can be treated with oral anti-inflammatories or steroidal anti-inflammatories. Rest may be indicated here. Okay, so I'm pretty vehement in saying rest is rare, but it's not completely off the table as a possibility for treatment. So finding optimal loading may mean completely unloading. Okay, aspiration, sometimes, with a chronic effusion, that may need to be drained by a physician. Cold application can help. Oftentimes you will get a synovectomy at no extra charge when you undergo a surgery. If someone's torn an ACL, they've probably got some hemarthrosis, they've got some synovitis in the joint. It's pretty typical that the surgeon's going to kind of clear that out while he or she is performing whatever he or she is performing. Cartilaginous injury usually leads to synovitis as well. This is where we get activity-mediated effusion, where you get an athlete, usually it's going to be like a recreational athlete, and they go for a jog and their knee swells up. Okay, well, that cartilage insult leads to that inflammatory cascade that we've already discussed, and then they end up with swelling inside the joint. Okay, so we can end up in this kind of self-perpetuating cycle where synovitis leads to cell death. We get this ingestion by the white blood cells. They eventually die, and they release those proteolytic enzymes. We get attacking of otherwise good tissue lining the joint, and we end up with cell death. So we kind of perpetuate this cycle upon itself. We know that articular cartilage doesn't have direct blood supply. This process actually changes the viscosity of synovial fluid, and if that viscosity goes down, then its ability to kind of cling to the joint surfaces is altered. So the nourishment of the articular cartilage is actually impaired by this process, which again, it self-perpetuates. If you're not able to nourish cartilage, then it's not as healthy as it should be, and it's more likely to enter this cycle. Okay, hemarthrosis can result in irreversible damage to the joint. Okay, if a physician aspirates a joint and there's blood in it, that's an even worse sign than if it were just that straw-colored effusion exudate, the stuff that's ordinarily in there. Blood in the joint is a bad thing. It can cause articular cartilage damage, an irreversible decrease in proteoglycan synthesis, and then a slower return to normal rates of synthesis in the joint. So if we've got an individual that's suffering with an activity-mediated effusion, if they've had it drain and there's blood there, then we know that whatever we're doing isn't optimally loading enough. We've got to figure out a way to prevent that from occurring. The capsule itself reacts to inflammation in much the same way as synovial tissue, and over time it can become fibrotic and scarred, and it will lack the extensibility that it once had, further increasing the risk of additional injury. Okay. We also know that many of our ligaments are actually just thickenings of the joint capsule. So an intra-articular problem in the knee joint can certainly lead to MCL degradation over time because it is continuous with the joint capsule. So if we've got individuals who are consistently reporting effusion or edema, then without a lot of pain, it's still really not okay to just let them play through that. Now, mobilization, it's bad. Okay, there's your bottom line. Ground substance is reduced. We get increased collagen cross-links, which we'll look at a picture that illustrates that. Basically, it means we're going to become less mobile, more inflexible. The tissue becomes dense, hard, less supple. Okay, so this poor guy, he's got a cast on both arms. When he comes out of those casts, if he were to try to do a Phelan's test or a reverse Phelan's test, he's going to feel like his wrists are going to snap off because no movement in that tissue has led to cross linkages and density. And ordinarily we would think, oh, well, that's good, density, that's good. But in this particular tissue, we're looking for elasticity and mobility. Okay. Wound contraction also reduces range of motion. So if we've got a post-surgical case, they're also dealing with the surgical portals or the incisions, and that can alter range of motion in and of itself. Okay, so ordinarily we've got these collagen fibers represented here as B to D, or B and A actually. Now, this fiber can slide in either direction ordinarily under normal motion, but with immobilization, our body actually, because of that density we said, it lays in additional fibrils. And the reason it's called a cross linkage is you see it's tethered to both of these. So this additional fiber is going to prevent motion in either direction in multiple planes. Okay, so it's going to significantly impact range of motion. And sometimes in order to get range of motion back, we actually have to physically break these cross linkages, and that's a very painful process. And if not painful, at the very least lengthy. Okay, so what we see here in group A, normal muscle fiber, where it's most obviously different, we see this white signal here that indicates fluid. Okay, so in D we see a significant decrease in muscle fiber area, and we see in all of these we see an increase in non-contractile space. Okay, so intramuscular connective tissue is seen in the immobilized groups. So you see that most markedly in D. In this particular study, this was a rat study looking at tibialis anterior, and these were uninjured subjects. They were just immobilized. So if we couple an injured athlete with immobilization, then we can expect to see these negative adaptations to a lack of stress. Okay, without stress, a structure becomes weaker. The collagen mass changes, so it becomes essentially brittle, less strong, less flexible, essentially everything we don't want for optimal performance. Okay, muscle fiber size. We don't lose muscle fibers from immobilization, but we lose size in the fibers we have. Okay, so in the elderly, we will see sarcopenia. In our normal healthy population, we'll see atrophy. So that particular cell decreases in size. We don't have conclusive evidence that tells us we lose myofibrils. That's been posited for a while. It's been seen in some animals, but not seen in humans. Reduced oxidative capacity, increase in fibrous tissue and fatty tissue in the muscle, so basically non-contractile elements start making their way. So even if we do like a circumferential measurement around the arm, for instance, or in the case of a knee injury, we might measure their quad. We might not see a huge difference in circumference, but it's the quality of the tissue that's fundamentally changed. If the fibers have atrophied, but we've got increased deposition of fat tissue or fibrous tissue that's non-contractile, then it may not change at all in terms of cross-sectional area, but in terms of effectiveness and strength, it may change substantially. Okay, so it's good to get those circumferential measurements, but we also want to look at things like main muscle tests. 6 weeks of elbow cast immobilization in one study resulted in greater than 40% decrease in muscle strength. Another study looked at the quads, saw a 25% decrease 4 to 6 weeks, and these are non-injured subjects. They were placed in long leg immobilizers just to see what impact that had on the quad. So in the case of like an ACL injury, we may have a couple weeks prior to surgery where the surgeon wants the effusion to go down. Okay, during that time we will do prehab. We will try to train the quadriceps. We'll try to train basically everything around the knee joint to make it as strong and as functional as it can be prior to surgery, because we're expecting those losses. Okay, so if we start at a baseline and we expect loss, then this approach says, well, let's elevate the baseline so that when we do have loss, we'll be able to get back to our initial injury levels that much faster. Okay. Other things we see in muscle tissue, vascular changes. We can see atrophy in as little as 2 weeks. Our proprioceptive systems are compromised. This is one that should be on your problem list, but oftentimes isn't, and it gets trained kind of indirectly. And I would encourage you to train proprioception directly. Specifically choose exercise modalities that are going to trigger changes in the proprioceptive system, because if we're sending them back out there and all they've done is feed forward type drills where they knew what to expect, then we haven't trained the proprioceptive system. Okay, histologically, the muscle tissue basically becomes less efficient at energy production and usage. Okay, clinical changes, measurables. Okay, we will see a decrease in their 1RM. We will see a change in range of motion partially mediated by muscle tissue changes. Okay, most specifically, type 1 and type 2 fibers both atrophy during immobilization, but the contractile ability of our slow twitch seems to be more adversely affected than our fast twitch. Okay, so initially we may want to do low intensity exercise, which is perfect. That's not to say we don't eventually want to do explosive type movements, but the problem is those muscle fiber types require a greater threshold in order to be recruited. And during that initial time of healing, if they're in the inflammatory phase or even the initial remodeling, oftentimes it's difficult for us to trigger that threshold because the forces involved exceed the capability of the tissue. Okay, so that's really something where optimal loading says we can't get a type 2 fiber response because the tissue isn't ready for it yet. Okay, we do see negative changes in the myotendinous junction, up to a 50% decrease of collagen and muscle cells. So gradual transition back into activity is how we have to go. And the longer they've been immobilized, the longer that reintroduction has to take. Okay, for articular cartilage, same thing. It's all bad. Okay, necrosis in areas of constant pressure, less organization, fiber fatty tissue, irreversible damage. The longer they're immobilized, the more likely they are to have irreversible change. Periarticular connective tissue becomes thick and fibrotic. These glycosaminoglycans, GAGs, and the water in the ground substance decrease. Okay, so sometimes people refer to ground substances like the grease in the joint, if you will, and if that becomes dried out, then it's going to negatively impact mobility. Okay, so we get those cross linkages we talked about, cellular death, inflammation. Overall, bottom line here is decreased range of motion. So in muscle tissue, we said decreased strength. Connective tissue, we said decreased range of motion. So the key to keeping articular cartilage, for that matter muscle, all this stuff healthy, is joint motion of some sort. It doesn't have to be loaded, but an immobilizer or a cast, you've even seen a change in that. Putting someone in a plaster cast or a fiberglass cast doesn't occur nearly as often as it used to. Hopefully you saw last year with Ken Fox when he came in from Don Joy with the removable splints. Those are helpful because, yeah, they do allow hygiene. They're more comfortable. You can swim in them. You can take a shower. But they also allow, in a controlled environment, in therapy, we can take that off and undergo some safe, pain-free range, whereas we couldn't do that with a fiberglass cast. So joint motion is our friend. And if they haven't been immobilized, it's even more important, okay, because that tells us that we're allowed to progress at our own rate. Okay, ligaments don't necessarily atrophy, but they do change in terms of strength. Okay, much like we talked about with muscle tissue, where the fibers atrophy and then it fills back up with fibrofatty tissue. A ligament doesn't necessarily atrophy, it doesn't necessarily change in size, but the tensile strength of it can be negatively impacted with immobilization. Okay, so bottom line here is optimal loading. Okay, anything I can do to minimize the duration of time that they're immobilized is going to be beneficial for healing. Anything I can do to start to reintroduce loading into that tissue is going to start that process of remodeling that much sooner. Okay. Remobilization is essentially just the opposite. So what we're looking at here, this is a bone tendon bone graft for an ACL repair, and this is what's called a quadrupled hamstring. So we'll actually take a hamstring, fold it in half, and then tether it together with sutures, and then put it in place. Okay. Now, if we've been immobilized due to surgery, we know that the quads are more predisposed to atrophy than hamstrings. If we've got an athlete that's undergone ACL reconstruction, then they need the hamstrings as a dynamic restraint to anterior translation of the tibia. Okay. A bone tendon bone autograft, we harvest this out of the patella. It seems to weaken the quad more than a hamstring autograft. Okay, weakens the hamstring muscles. Research tells us that quad strength is slower to return than hamstring. Okay, so what this means for rehab is not every ACL reconstruction is the same. You really need to know what was done, or if it was cadaveric, if they have an allograft, then we don't have to worry about what happened at the harvest site. All we have to worry about is protecting the joint that's been reconstructed. Okay, we can use electric stim, biofeedback as tools to help minimize atrophy. Helps the athlete know, or the patient know, that they are getting muscular contraction, and that can take many different forms. We'll talk about that in lab. For articular cartilage, this can begin to return to normal, but remobilization must consist of controlled stresses. Again, stepwise progression back, not just immobilization to full return to play. We can sometimes see evidence that we've done too much. You know, if we've done an aggressive rehab session, they come back in the next day and they've got a massive effusion, then clearly we've overdone it. So we need to take a look at what we did. Was it a volume issue? Was it an intensity issue? Was it both? Was it the specific exercises we did? Okay, so I always want you to be critical of your rehab, and part of understanding your exercise prescription comes immediately. They'll say, oh, that didn't hurt, it was okay. But the other part of that comes the day after, or the next time you see them, and that's when you're gathering that information. Just a simple conversation. How did that feel? Did you have any pain? Did you swell up? Were you really stiff the next day? Soreness is okay. Pain is what we're trying to avoid. Okay, so early treatment helps us prevent synovitis, damage to the joint capsule and the articular cartilage. Ice is being increasingly debated for its role. It's still indicated, but that may change during the span of your career. But it's still considered an important adjunct for minimizing pain and inflammation. And if we've got prolonged effusion here, we're talking primarily the knee. If it's left unchecked, this can result in synovitis, and then we enter that synovitis cycle that further degrades the joint capsule. All right, we'll talk real briefly about quad shutdown. Anytime we've got effusion, we also have a reactive muscular inhibition that occurs in the quad. And volumes as small as 20 to 30 milliliters, which you probably can appreciate with a sweep test or a bilateral patella test. This is basically, they'll feel tight, but you won't be able to definitively tell that they've got an effusion of that size. Usually you're talking 40 milliliters or more before you can really appreciate it. But if if they have an effusion of that small of an amount, studies have shown a result shown up to a 60% decrease in quad function. Okay, the vastus medialis oblique is the most sensitive to small volumes, and it can be shut down. That can certainly negatively impact quad tracking, can lead to anterior knee pain, and then that quad shutdown is going to lead to instability. Okay, their dynamic stabilizer of the quad is going to be compromised. So clinical implications here, bottom line is, if they've got an effused knee, we've got to find out why it's occurring and secondarily try to treat it, because if we leave it and let them try to play through it or fight through it, it's eventually going to lead to another injury or a more significant problem. Okay, for connective tissue, we're going to prevent abnormal cross-link formation. It's much easier to prevent cross-linkages from occurring than it is to treat them after the fact. So this is why a runner stretch like Kermit's doing here, figure out what it is we can do to try to keep them mobile. If you've got an athlete that suffered a shoulder dislocation and they just had a reconstruction, it wouldn't jump to the top of your consciousness to have them stretch their hips and do something like an aggressive runner stretch, but that's absolutely appropriate. Okay, this might take the form of a home exercise program. It might be they're on field for the day, but maintaining flexibility in the lower extremity while they are out of participation can make your life a lot easier on down the road. So like we said, those laminated forms, maybe you've got a hip global mobility circuit that you have them go through, and every third day they have to go through that. Remobilization positively impacts muscle fibers, articular cartilage, periarticular cartilage, connective tissue rather. The thing to remember here is the longer they're immobilized, the harder it's going to be to reverse. And even if it's submaximal type activities, some sort of mobility work is going to pay dividends for you down the road, provided you're not causing additional tissue insult. Okay, arthrofibrosis, see this white signal here. The joint is visible in this lateral view. We get scar tissue around a joint after surgery or injury. This may be more common in some athletes than others if they have a tendency to scar out on their skin. You get an athlete that keloids very easily, then surgery is going to be a big deal, because if they'll develop scar tissue on the surface of their skin, oftentimes they'll develop scar tissue elsewhere, and a surgical incision will scar. Okay, this is usually induced primarily by that immobilization. So trying to keep them mobile or moving them to the extremes of whatever the physician has prescribed for them is going to help you, because otherwise that tissue is going to have to be broken, and that's painful and hard. So treating arthrofibrosis means early range of motion. This is one of the reasons I used to put patients in passive range of motion, continuous passive motion machines. Okay, so we see following surgery they get that hemarthrosis. It hurts. That alters their muscle activity. We get more synovitis, further muscle shutdown, we get adhesions, and basically if you've got a patient that's here, they don't want to move. Okay, so if they're going to hurt regardless, let's try to get them moving early, and we can basically build upward from this. This isn't even a cycle, this is just a series of things, whereas this is cyclical and it's going to build on itself and it's going to worsen over time. Okay. For ligaments, can take up to a year. That's the bottom line. You can read through this if you want, but remodeling, return to pre-injury levels can take up to a year, and it may not ever occur. Okay, so they may always have instability or a lack of stability in a particular joint. Okay, for bone, permanent bone loss, irreversible, can occur. 12 weeks of mobilization You'll see this, they put a kid in a cast anymore. It's going to be 4 to 6 weeks. They don't want to leave him or her in that cast any longer than they have to. Even if they are in an immobilizer they can't remove, isometrics can be utilized there. Even just loading bone through the attachment points of the muscle is better than nothing. Okay. Isotonic exercise is going to be even better because we're actually introducing some load. All right, that's it for this section. Sorry I didn't get it done in class, but still adjusting a little bit to our new schedule. I will see you tomorrow in lab. So have a good one. Take care.